Good morning, everyone. This is Dr. Rohit Gupta from Movement Science Academy. And first of all the thanks to SCAP for organizing such a youth feature webcon and having thousands of people on one platform. All thanks to Dr. Mudgil for getting all the people, all the speakers on one platform, sharing the knowledge, different subjects and topics, and making it for 3 days. So it's always good to talk about our sharing our skills and the knowledge with the people. And I'm so happy to be here today. So I hope everybody is safe and doing well in this lockdown, Corona time. So our topic of the discussion today is that motor control and the motor learning with the PNF. So there have been several methods for the same. There have been different theory when we talk about motor learning and motor control. So some of the students are also connected with us and some of the therapists. So we are going to make it like in concise manner so that everybody could understand that. And we are going to just talk about how do we see this model according to the PNF approach. So, lots of messages. Good morning, everyone. Good morning. Yeah. So, the first thing I want to start with the PNF because we are going to discuss this motor learning and motor control with the PNF way. So, I hope most of you must be using. There's a question starting how to apply motor control, motor learning in daily practice with PNF concepts. So that's what I'm gonna come on that. So let's start with the PNF. So what is PNF? As it stands for proprioceptive neuromuscular facilitations. So I hope you know that the proprioception means it's all about the receptors getting the sensation of the joint positions, muscle spindles. So it's all about your like your body positions, all the sensation to the brain, proprioceptions. When we talk about neuromuscular, it's all about having to do something with the nerves and the musculoskeletal system. When we talk about facilitations, it's all about making something easier or enhancing the recovery. That stands for your proprioceptive neuromuscular facilitations. So before going to motor control, I just want to tell you something about these concepts only. How do we look at this model and how do we talk about this? Well, again, I want to share you that the PNF was given to the world in 1940s. By Haban-Cabart and Maginot. So Haban-Cabart was the neurologist, Maginot was the physical therapist, and then they describe it further. And the most research was done by the Norton Voss, Maginot, and another therapist Voss. There is a now International Pnf Association. There is a Kaiser Foundation in USA who are working together, and the courses runs over all over the world. So I have personally done level 1, level 2, level 3A, level 3B, level 4A, level 4B from IPNFA, and I have been teaching PNF since last almost 3.5 years, and I have taken something around 34 workshop. My voice is not clear. Probably I just need to use that a second. I hope it's better now. Yeah, so I've done certain levels in the PNF and have been teaching the PNF, doing some research work. So when we talk about, there was a scientist before and he said the brain knows nothing of individual muscle action, but knows only about the movements. So when we talk about, suppose I'm doing this movement, I'm bending my elbow right now. I'm doing this elbow flexion. So which muscle is working right now? If you just give me the answer, which muscle is working right now? Yeah. So as we say that biceps, but it's not only the biceps, of course. It's the brachialis, concentrically. At the same time, there is a triceps which is working eccentrically. So when we talk about any of the movement, it's not a single muscle, it's the multiple muscles which works together. And that's how our brain learns about the movements rather than the single muscle. Even if I'm doing this finger movement, I'm flexing this, there's a muscle working concentrically, eccentrically, different muscles. So it's never a single muscles. When you talk about follicular contraction and something, that is different. But when we talk about movement, it's a multiple muscles working together. So that's what we need to understand, that we should look at the movement part and how we can improve the movement into our patients. There was another scientist, Duchenne, and he said isolated muscle contraction do not occur in nature. If one muscle is contracting, the other muscle will be contracting somehow, other way. So these are the things we need to understand. Now when we talk about motor control, motor learning, the people always used to think that it's only for neuro patients. It's only and only for the like stroke, head injury, Parkinson, myasthenia gravis, these kind of conditions. But it's not like that. Everybody needs motor control. If I have a lower back pain patient, if I have a cervical pain patient, the patient needs motor control, motor learning. If I have a patient with the sports injury, someone comes with the sports injury, with the shoulder injuries, tendonitis pain, any like ACL injuries, any other, sports injury, even they need the motor control and the motor learning. Because when you're working on the pain management, you might use ice pack, cold packs, you might use certain methods like soft tissue release, needling. There are a lot of things to work on, and everything is lovely to work with. But does it last long? That's what we need to understand. You might relieve the pain for some time. The pain might come again when you talk about the modalities also. When you use that different electrotherapy modalities also. What lasts long is the motor control. When you teach your brain, when you give the feedback to your brain, that matters. It's all about feeding the brain. That's what I say sometime to my therapist, to my students, to my patients sometime, that especially in the terms of the neuro patient, that we don't exercise your body, we exercise the mind of the patient. And that's why we have to feed the brain. So that's how we have to go on. So Surya is messaging me. Surya, I'm online only itself, if you can see me. Alright. I'm already on the Facebook page. So that's how we work on. Okay. Now we're going to discuss about some of the theory regarding that. How do we use that? The motor control and the motor learning, the PNF. So first thing I want to tell you is that functional exercises. We do some exercises for the structural base. So we do three kinds of level of recovery basically. We do recovery at the structural level when we talk about the muscle, like healing the muscle tissues, working on the bones, working on the ligaments and these kind of stuffs. Then we talk about recovery at the function level when we work on the functional activities. We directly train our patient for the functional activities. And then we do the recovery at the participation level. If there is a sports player or anyone with the skills, like we do the particular skills, so we give the training at the skills level, at the participation level. That's how the training goes on. So there's a question, Pnf stroke, when to start? The Pnf stroke starts from the day one. If your neurologist allows you to do the physio, why not? Even if I found a patient of like having a very low muscle strength, like 1 plus 0, I can do the PNF. It's more about activations, but yes, I can work with start with the rhythmic initiation, passive also, and I can go for the 3-dimensional movement. At the same time, I can start from the day 2, day 3 for the setting balance, PNF. So it can be started. Is PNF applicable post ACL arthroscopy? Why not? It is. So it's a Harsha. The first thing I do is that I start from the day 2, day 3, is recruiting the glutes by irradiation and reinforcements. So probably I'll share one of my video working for the ACL. So I work on the reinforcement of the glutes. I take the patient, the foot close to the wall, and I do the movement from the opposite leg, and that's caused the irradiation, and that reinforce the weaker glutes muscles. At the same time, I work with the ACL reconstruction for the loading response. So I take them into the stranding and I use my elastic band and I train them for the loading response. And that's a lovely technique to work with. So I can share that video as well. Yeah. So we'll take some of the question a little later on. So because we have to go on. Yeah. So when we talk about the motor learning, the functional exercises matters. It means the exercise should be performed in activity oriented way. Then we also talk about the plasticity. I hope some of you know about the plasticity, how the plasticity goes on. So repetition and the processing of the input always leaves a track in the brain. But there is a self-healing of the brain, self-regeneration of the neural tissues. That's all about the plasticity. Yeah. Now, I want to talk about the definition of the motor control. What is motor control? So, the motor control is basically the study of the posture and the movement. It's all about the study of the posture and the movement which are controlled by central commands. So, if you are maintaining your posture and if you are doing a purposeful movements, these are all controlled by the central commands and the spinal reflexes. Also the function of the body and the mind which guide these movements. So it's all about the stage of posture, movements in the task-oriented way, and that comes from your central command. That's all about the motor control. Yeah? Okay, we'll come to the other questions. Yeah. When we talk about motor learning, it's all about the process connected with the performance-oriented experience. Once again, I'm going to talk about that. The process connected with the performance-oriented experience and which lead to relative permanent changes in the capability to react in handling situation. So it's all about creating the changes to the brain by performance or the experience. If someone knows about the movement, we feed the brain regarding those movements. So when we do the repetition of the same, there is experience of this movement to the brain again. It's like a feeding to the brain again, which leads to some permanent changes toward the motor control. So that's all about your motor learning. This is basically a process connected with the performance and the experience. Okay? That's all about your motor learning. So it's all about the activities which we are feeding, the experience which we are giving to our brain. So how do you deal with Pnf commands with people with hearing defects? Well, I don't work with hearing defects now. I don't work with that with the Pnf now. Sorry. So the motor skills developed out of the need to solve problems. When we give that feedback to the brain, when we work on the learning, the motor skills develops over the time into the brain. When we talk about, so basically we have taken the 3 phases of the motor learning. There is someone who says that the Pnf can be done in 1++, alright, but there is a very high chance of fatigue. How we correct it? Why do we have to fatigue the muscle? It's not that way. We can do the irradiation treatment also with them. We can reinforce them by using the positive side of the body as well. We use the approximation for them, but of course we have to keep in the mind that we are not giving the fatigue to the muscle. Because that's how you have to go gentle with the patients with no pain and respect the pain. Either no pain or respect the pain to the patients. So as a therapy, you should know when you can fatigue the muscles. You should know about that. That's all about that. Please tell us about chest, respiratory Pnf for breathing betterment. Wow. For respiratory and chest, it's lovely to work with that. I worked in Apollo Hospital, in the Prastha Apollo Hospital for 5.5 years. And I worked in Max Saket, New Delhi for 1.5 years. So around 7 years I spent in hospital, and I worked in ICU, I worked in CCU, I worked in wards with a lot of cardiac patients, and I work with the PNF for all of them. And we use the sternal breathing, we use the diaphragmatic breathing, we use the rib cage facilitation exercises by using scapular pattern, by using upper limb patterns. We use the stretch reflex. We talk about the reinforcement of this area. We again talk about for the COPD patients, the huffing and coughing with the PNF. So there are a lot of tactics on the PNF we work for the breathing, and it works very well for all the patients. Yeah. Okay. So when we talk about the 3 stages of the motor learning, there are some stages. The first comes to the cognitive. Yeah, so the cognitive stage. So it is characterized by understanding of the task. In the first stage, when the patient has lost the movement, or a patient comes with after a fractures, injuries, and forgets about doing that movement, that functionally and the purposefully. So what do we do that? The first stage comes the cognitive. When a patient develops understanding of the task, a task is given to the patient understands that. It allows learner to assess ability and task demands. So it allows our patients to learn about his ability, his or her abilities, and the task demand, what the task is asking from them. So it's all about, first stage is all about understanding of the task. Suppose I take example of the stroke, and somebody get the right hemiparesis, and we give them some task. We give them like, hold a glass of water, or I have a bottle here. Take this bottle and have it from your mouth. Get the water. So the first stage, the patient understand about these movements. He or she develops into the mind understanding of this thing. Then the learner assess his or her abilities, how he can do it effectively. Does he need some supports? Does he or she need some supports, assistance? What kind of information more he or she needs? More information to the brain, some more complexity. So it's all about the task demands. That comes in my cognitive phase. When we talk about the second stage, that's your associative phase. So when we talk about associative phase, the learner learns something and it start doing the practice. So the patients, he or she, start doing the practice and refines motor learning to the brain. Okay? So understanding has been done in the first stage. The patient is basically learning that, doing the practice, and getting the motor learning, giving the feedback to the brain. It's like feeding to the brain all the time. The spatial and temporal organizations increases into the brain. I'm not going to touch that into the detail, the spatial and temporal organization which are there in the brain about the learning, about the organization of the movements. We also talk about the cortex, the sensory cortex, the motor cortex, how it goes, how it carries the sensation, how it's been feed up over there, and how the response comes from the brain to the muscles, to the joints. So I'm not going much into the detail, but the spatial and the temporal organizations increases in the associative stage. The performance becomes a bit more constant. It becomes more constant over the time with the repetitions and the practice. So there's a question about the facial PNF. I will come to that. After the second stage, we talk about the third stage is the autonomous. When we talk about autonomous, it goes at a high level. The autonomous motor learning is all about when the patient starts learning on himself or herself and goes for the high level training. It is characterized by automating and maximal transfer into the pluriformity in the brain. If I take an example of a patient, a stroke patient with walking the difficulty, in the first stage we teach our patients to stand, to take some of the steps somehow. The patients, after getting some muscle strength, feels like, okay, this is how I have to stand. This is how I have to maintain my posture. And this is how I have to take one step or this way. So it's that the patient understand in the first stage, cognitive. If I talk about like associative, the patient start practicing that particular things and refines motor learning. So it becomes easy for the patient to stand, to take some steps forward, going with the balance, maintaining that. The organization become better, spatial and the temporal organization becomes better, improves. When we talk about the autonomous, this temporal and spatial organizations goes to the high level, at a very very high level, and the patient start walking into the all the directions, like we give training to them in the forward walking, sideways walking, backward walking. So that's all about goes as a high level learning, the autonomous. That's how we work with the motor learning process. Yeah, I hope you have got some of the idea about that. So then we talk about as we say that the motor control, they have in different theory. We talk about closed loop theory, we talk about schema theory, and it's all about giving the feedback to the brain and working on that. Now if some of you are here are the righty or some of you are here are the lefty, if I ask some of you people who are righty to write your name right now with the left hand, if you are lefty and I ask you to write your name with the right hand right now, what will happen? You'll find it a little difficult. But if I ask you to write from your dominant hand, it will be quite easy. Why is that so? Because that's how you have been feeding your brain since beginning, since your childhood. That's how you were trained, your brain was trained about it. And that was the motor learning to the brain in the beginning, and over the time there was a motor control. Because when you were a child, when you were taught to write something, that was difficult, even with your dominating hand. At the same time, if I ask you to write from your non-dominating hand right now, and if I give you that activity for 20 days, the 21st day you will be much better. If you have seen some of the rehabilitations, like once you get the one arm completely get denervated because of kind of injuries to the spinal cord or something like that, or when you see some of the high stroke cases, AMS infarcts, when there's the heavy stroke, severe stroke, and you get no movements at all, even after doing a lot of movements and all, what you do? You start training the other hand to perform the activities which you were doing from the affected hand. And that's what you're doing, is that motor learning, motor training. And that's how it's very important. If I take an example of my back pain patients, and they come to my clinic. We have a clinic in Gurgaon. They come to my clinic. I work them sometimes with the needling also. I do that ice pack, hot pack, mobilizations. I do that Mulligan Maitland also. I do that a lot of things I do with them. They feel reliefs. They are being mobilized. I do manipulation. They feel much better. But for their long term, I work on motor control and motor learning. I train them. I work on their stability. I work on the pelvic movements. I work on rhythmic stabilization, stabilizing reversals. These are some of the techniques in the PNF in which we work on the core contractions of the muscles. There's a dynamic reversals also into the PNF when we work on the antagonist and agonist, and we work on the both in the concentric manner. So we give the concentric contraction without relaxation in dynamic reversals. We work with the stabilizing reversal and rhythmic stabilization, which helps them to get the stability into the affected area, and it develops the balance reactions. It gives them it basically feeds the brain about learning the position, the movement. So if you perform those techniques, especially the stabilizing reversal and the rhythmic stabilization, it's going to work very well. Probably you can go to my Instagram page, drrohit20. I have a lot of videos on my Instagrams about rhythmic stabilization and stabilizing reversal. If you go on Dr. Rohit 20, Dr. Rohit 20 on Instagram, there are lots many videos there. So you can go on that page, and we have put a lot of videos about how we work on the stability, balance, learning to the brain. I also have a couple of videos of hand training, learning to the brain about the functional task activities, working with like carrying the glass. Like I do train my female patients how to put lipstick, how to comb the hairs. Well, I'm having the terrible hairs at the moment just because of I'm not able to go to the salon because of this lockdown. So I train them for performing these activities. I stabilize them into the same. Like if some of my patient is able to do to go to this level but cannot go over the head just because of not having enough strength into the shoulder muscles, what I do in this activity only, I try to work with the stability. So there's a different kind of learning to the brain. Basically, we need to understand as a therapist what our patient is needed. And trust me guys, when we talk about recovery, if you don't work on motor control, motor learning, you're not going to get the permanent changes or the long-term changes. You need to work on it. This is a subject which I believe so, because when I discuss with my some colleagues, when I discuss it with my some of the fellow physios, some of the people they neglect this area. But I would like you to go read more about this motor control, motor learning, to how to work it effectively in sports patients. Like when so I want to take something about on the sports. Yeah, so I got a patient something like 2 months before, so before the lockdown, and there was a girl, 13 years old girl, suffering from the shoulder pain. And the pain was basically more about when she used to serve the ball. If you have played the tennis or if you watch the tennis, so when she used to serve the ball, or when she used to go for the volley, so serve and volleys. So when she used to go for volley basically, and she used to feel the pain to the shoulders. She had some of the sessions of the physios at different clinics. When she came to me, I work on that stability of that area, but again at the same time I work on the stability of the scapula. Then she got much better. She returned to the sports, but again she called me after 3-4 days that, doc, I have a little more pain. What I did is that I went to the ground. So that was like training at the participation level. I went to the ground and I trained her. I basically changed some of her positions. So that was like giving some feedback to her. So I work on that way, and she learns it much better in such a way. She changed something with the position, the way she was serving, stability, and now she's performing at a national level. So that's how we can even change the sports performance with the PNF. So we can do a lot of things with that. So I'm going to take some of the questions now. Can PNF increase muscle power and muscle length? Guys, I cannot take all the questions because we have limited time. I have something around 5 to 10 minutes. So, okay. So can PNF increase muscle power and muscle length? Yeah, why not? We do the elongation. You know what? Pnf stretching is one of the best way to get the flexibility. The Pnf stretchings, when we talk about hold relax, when we talk about contract relax, when we talk about initial stretch, when we talk about re-stretch, we do the initial stretch at the beginning of the movement to initiate the movement better. We do the re-stretch sometime to activate more motor units into the particular activity. So it's lovely to work with PNF stretchings, PNF elongation for length, and of course, when we talk about dynamic reversals, the optimal resistance training into the patterns, we improve muscle power, strength, endurance, and everything. What would be the pattern for PNF? So it's not about just one pattern. There are more than 40 patterns in the PNF. It's not just one pattern. The people, when I go and I ask them, what do you know about the PNF, guys? When I go and I teach in Mumbai, Pune. Even I have trained therapist in Bangladesh also. I have trained therapist in Sri Lanka also. I was going to teach in Malaysia last month, but I postponed the plan because of this thing, Corona. So this is a D1, D2, and I say how many patterns are 3, 4, 5, 6? No, it's around 40s, more than 40s. There are a lot of patterns for the upper limb, lower limb, scapular, pelvis, head and neck, trunk, chopping, lifting, bilateral upper limb, bilateral lower limb, thrust pattern. There are a number of patterns we work with. So there are hundreds of possibilities to work on my patients with different patterns, combining with different techniques. Because we have in PNF we have procedures, principles, philosophy, techniques. So PNF is this much of big approach. It's not this much. It's a big approach when we talk about PNF. I'm going to take some of the workshops as the lockdown goes away, and some of you can join that. Some of you can join our Insta page, and so there's a lot of possibility to work with that. So we take some of the more questions. Can we use PNF in any muscle tear? Yeah, we do that. If the muscle tear is it's a partial tear. I just had a patient with supraspinatus partial tear, came to my center with pain, and the patient is basically was like kind of a player, was to Dr. Santhil, if you are there on or any of the member, Dr. Mudgil, Dr. Manoj, if you are there on the Facebook, I just need 2-3 more minutes. That's how, and I'm gonna finish my things. Yeah. So what I did is that even I advise my patient to go for PRP, plasma-rich protein injection, just for the healing. But I started the PNF from the day 2, because if you have a partial tear and if you work with gentle, hold, relax, and if you work with reciprocal inhibition, if you work with dynamic reversal into the available pain limited range, if you work with dynamic reversal, that all about your agonist and antagonist concentric contractions, like I'm doing these patterns, flexion, abduction, rotation, and extension, adduction, interrotations, that heals and that gives learning to the brain again. So I use that in the muscle tear. Of course I use that, and the patient got much better in few. The patient was the patient is Muay Thai boxer in the Thailand. So he's a Muay Thai boxer, if you know about that. All right, how's the PNF used in rehabilitation? All the way, all the way. Rehabilitation is a big subject. Big subjects start from the initiative phase to the advanced phase, intermediate phase, sports rehab, neuro rehab, ortho rehab. I use PNF in each and every time. I love PNF. I have PNF in my blood, so I do PNF all the time for the rehabilitation and all. All right, how PNF is helping multiple sclerosis? Well, when you talk about MS, you have limited stuff, because you have to think about the fatigue also. You have to think about the limitation of the patient. You have to think about the prognosis also. But yes, you can work on the activity of daily living with the PNF. You can work on some of the balance, some of the stability, some of the help them to transfer from the chair to the bed if they are in bed phase. So there are PNF at the high levels of training, standing, chair shifts, everything. So we can help them with the PNF in multiple sclerosis in many ways. But that all depends on the stage of multiple sclerosis. That depends on your assessment. Does PNF use in cerebral ataxia? Oh, lovely to work with that. Yashika. So I work with the cerebral ataxia. I work for the coordination. If you have seen like the patient with the incoordinations, like we teach them for the upper limb, we teach them to go for finger to finger, finger to nose. What I do with the PNF, I work with dynamic reversal, and it helps in bringing the coordination, speed, accuracy. At the same time, I work on the lower limb. We do the gait training in the PNF. It's a half-day things. We do that sideways. We do that registered guided training. We work on the PNF motions. So there are a lot of trainings for the PNF, for the So we do work in the lots of different way for the ataxia. Yeah. Facial PNF, we work with the irradiation reinforcement. So suppose someone is affected this side, I can work on this side of muscles, doing more strengthening. What I do is that I cause irradiation, I reinforce this. So there's a lot of possibility of the facial PNF. We do that. We do the PNF for dysphagia management also. So it works very well, very well. Respiratory PNF patterns is not possible today. I'm not going to demonstrate right now. I have a couch at my house. If you see that I have a couch here, but yeah, I don't have a model at the moment, and my time is gonna finish. I'm just getting the message. So, guys, there are a lot of questions. What you can do is that you can goes to the Movement Science Academy page, or you can go on my Rohit Gupta page, and you can go more on DROI20 Instagram page. You can drop your questions me over there. I'm gonna answer to each and everyone, possibly, I don't know, but I'm gonna answer to most of you people because the time is going to finish. It's lovely to connect you all again. Go and read out. There are different theories. You can go through the Sullivan book also for motor control, motor learning. There are different books, different theories. NDT also have some theories. Once again, thanks to Dr. Mudgil for doing all the things, arranging this webinar conference, getting all the speakers, giving us chance to speak out, connecting to hundreds of therapists all around. It's lovely to connect to all of you, and we are going to work again. We are going to see you again. Follow us and work on. Be a good therapist. Stay safe. Keep doing good. Bye-bye, everyone. Yeah.